Good evening and welcome to the RapidAI Insights to Impact webinar series. My name is Dan Actor, and on behalf of the entire RapidAI team, we want to thank you for joining us this evening. It's an honor to have three distinguished neuroscience leaders and clinicians with us today to share their real-world experiences, key learnings, and best practices using RapidAI for hemorrhagic stroke. Today, I'm joined by Adam Khan, who is an endovascular neurosurgeon at Corewell Health's Dearborn campus, Dr. Abhishek Singh, who is a neurologist and is director of the Comprehensive Stroke Center at CHI Nebraska, and Dr. Deepak Nair, who is the vice president of the Neuroscience Service Line at OSF Healthcare. In this webinar, we will explore how AI is transforming hemorrhagic stroke. We'll look at the impact AI is having operationally, clinically, and also administratively and financially. And along the way, our guests will be sharing their experiences and best practices in utilizing AI for hemorrhagic stroke. At any time during this presentation, we encourage you to submit your questions in the box on the screen. But before we begin, I'd like to start with a high-level overview of the Rapid Hemorrhagic Stroke Solution. This stroke solution is the most comprehensive hemorrhage patient management system on the market today. Rapid ICH and Rapid SDH are our triage and notification modules. Rapid ICH detects suspected acute hemorrhagic stroke, and Rapid SDH can differentiate between acute and chronic clot, both with industry-leading accuracy down to 1 milliliter lesions. Then we have Rapid Hyperdensity and Rapid Midline Shift. These are our measurement modules, and they provide the volume of hyperdense tissue associated with hemorrhagic stroke, and also the extent of midline shift. When implemented as a complete solution, these modules run on all non-con CT head scans across an entire healthcare network. And the Rapid Hemorrhagic Solution has been shown to be an integral part of a code ICH program, as we'll discuss today. To kick things off, our first topic is the emerging role that AI is playing in hemorrhagic stroke. Can each of you tell me a bit about your practice and the role that RapidAI plays in hemorrhagic stroke at your facility? Let's start with Dr. Khan.
Sure, thanks, Dan. So my name's Adam Khan. I'm an endovascular neurosurgeon. I'm about 2 years into practice. Before my current role, I trained at the University of Minnesota and University of Michigan. And I had experience with Rapid at both of these institutions. So I've had about 9 years of experience now. I now work at Corewell Dearborn Hospital, which is one of the thrombectomy capable hospitals at the Corewell Health System, which is one of the larger healthcare systems in the state of Michigan. So I essentially have nearly 10 years of experience with Rapid, and I'd probably say a good amount of my neurosurgery work now is also using Rapid, especially cranial work, using the hyperdensity modules to be able to help triage and facilitate a lot of the patients that I'm seeing right now.
Great, Dr. Singh.
Hi, I'm Abhishek Singh. I'm a neurologist. Long time back, 10, 15 years ago, we started when Rapid in 2012 came in. We started using very early on. In my center, we are part of a large, sparsely populated rural Nebraska setting and Iowa setting, where we have a large catchment area. We face challenges as any rural hospital will face. And Rapid was instrumental and is still instrumental in a lot of our compliance ask in Comprehensive Stroke Center, where I'm director at. And it helped me tremendously from taking a primary stroke center to bring a comprehensive stroke center in a short duration of time. So I'm very thankful for this technology.
Great, Dr. Nair.
Yeah, thank you. So I'm Deepak Nair. I'm also a neurologist by training, and I do still work clinically in our inpatient space, covering our stroke and critical care services, our flagship facility in Peoria, Illinois. And here this past year, I stepped into a relatively newly designed role as VP of the Neuroscience Service Line. And as such, we're kind of trying to focus on delivery of standardized and uniform care standards across our entire ministry. We are a Catholic healthcare system, and we're very mission driven. And as such, it makes it challenging where we also have many rurally based facilities where we're attempting to deliver a similar standard of care. And it's been a challenge to ensure that that same standard is being delivered across our entire system, but then also to ensure that we're triaging the right patients to be transferred to our regional hubs and our comprehensive center in the central region. So, we recognize that we have a few different tiers of care. And if you use the stroke paradigm, we have actually two comprehensive stroke centers, but of those two, my home facility is the larger one and really still operating at a tertiary quaternary level. And so we will sometimes even take really complex cases from our other comprehensive stroke center when that's appropriate. But in order to do those kinds of things, we have to create that local capacity. And one of my esteemed colleagues is fond of saying, we're a healthcare system with over 2,000 beds. Why don't we behave that way? Well, part of the answer to his question is that in order to do that, you need open transparency of data. That needs to be shared in real time, especially on the clinical side. And you need to have some sort of platform for communicating around that clinical data. And that's really the solution that RapidAI provides for us. And with the advancements that Rapid has made, we're also now in the middle of considering a system-wide expansion to really be the glue that binds us all together.
Yeah, Dr. Nair, that's a great point of implementing AI for hemorrhage at all three levels of stroke care. And I think it's a great segue to the next topic, which is how can AI help optimize patient flow and accelerate decision-making? Dr. Khan, if we drill down from the system level that Dr. Nair just mentioned to focus on the patient level, how has RapidAI impacted individual patient flow at Corewell Dearborn?
Yeah, sure. So like I said, I use Rapid. I had been using Rapid before in other regards, more in an endovascular perspective. But now, as a neurosurgeon, it's probably 50+% of my practice. I get calls all the time for trying to triage patients who have some sort of hyperdense lesion in their CAT scan. And as you can see, how typically it works at most hospitals, whether it's one I'm taking call at or one that I'm on their roster and they don't have an on-call neurosurgeon, and so they sometimes call me. Oftentimes what will happen is that a patient comes into the emergency department, they get assessed by the ER doctor, a non-con head CT is performed. It takes some time for that to be read. A radiologist then reads it. After that, a radiologist then has to report that to an emergency department doctor. At that point, maybe a mid-level, a neurosurgery mid-level or somebody else is contacted. And then after that, they contact myself or the other neurosurgeon on call. So there's a lot of lag time, a lot of waiting in between. And really, having RapidAI in my pocket, it's kind of changed that flow a little bit, where as soon as somebody comes to the ER, sometimes as soon as they get done out of that CAT scan, I've had it before where even the patient doesn't even get back to the ER bed. I've already gotten a notification that there's something going on. It's faster access to that information, faster decision making, and just faster coordination of the care, especially where it's from one of our referring hospitals that I know they're going to be giving me a call. Instead of it taking 20, 30 minutes for them to give me a call in order for that radiologist to reach out to the emergency department doctor and then the ED doctor then giving me a call, trying to page me, I sometimes initiate that myself and just give them a call as soon as I get that hyper dense notification. I can easily scroll through, and really, as an on-call neurosurgeon, it lets me plan my night. I get to figure out as soon as possible, as soon as something comes in, I get that extra. Even that 30 minutes makes me think, all right, can I start the case that I'm about to start? Say I have a small spine case or something else like that. I already know that I'll have at least that heads up in terms of what I can plan ahead of time. So, there's a lot of benefits that I have just in my pocket from using this app.
Yeah, those are all great points, Dr. Khan. Dr. Singh, both Dr. Khan and Dr. Nair mentioned optimizing patient transfers. What's your take on the patient transfer topic? You've been using RapidAI for years now across your entire system. How has Rapid affected your ability to manage patients system-wide?
So as Dr. Nair also kind of mentioned, that in a complex large network, issue becomes that do the transfer which are appropriate. So using Rapid as a triage, it kind of, and believe me, when there was time when we had to have PACS access to smaller hospitals, a smaller system, or a smaller sized individually, now it gives us a very good access to brain imaging, which is a part and parcel of stroke care, both hemorrhagic and ischemic, in our pocket. So I can triage patients who need our help from far away. So the remotest area which we transfer, these patients are coming from very, very far away. They don't have infrastructure to keep all these highly educated specialists. So they all come to Omaha, either to our center or to a different center from everywhere. So it helped me, what I liked about it, that it helped me to keep the patient where they belong. I don't want to transfer a patient who I know my neurosurgeon may or may not operate, my endovascular team might not be able to intervene. I want to keep that patient in their community. And some of the hospitals have some capacity of neurosurgery. They might not have in the night, but in the next morning, if somebody can come and see the patient, and while the patient is there, we can be a backup for them to manage blood pressure and anticoagulation, at least talking to the family via telemedicine or via telephone. So it has increased our ability to give some quality or some form of quality in my rural hospitals. And obviously, my administrators love appropriate transfers. We don't want to clog our comprehensive stroke center or thrombectomy stroke center with patient who does not need a transfer. So that is very helpful. And more than that, just imagine somebody coming to Omaha or far away, and then we tell them that nothing we can do, or we're going to just watch you 24 hours, right? In both cases, the family has to come all the way, find place to live here. It's a very, very different experience to the patients. So I think this is one of the examples I think we have picked about hyperdensity. So as we know, there's both detection, and the best thing about this particular software or AI technology is how accurate this is. So even if this hemorrhage is small, that hemorrhage will be detected, and it can go as close as at the error of 1 ml, 1.5 ml. So when hyperdensity came on first, we had a issue with it, but now we have slowly improved our versions. Now with that, false positive rates are not there that much, but we like to have those false positive. When we talk about very, very bad diagnosis, we want that false positive. So this particular patient, as you can see, small, tiny cerebral hemorrhage, I will not need this patient. I just need this patient still need a neurosurgery consult, but that patient will not be coming. It will save my bed in my ICU or neuro ICU, and it will be less cumbersome on family and patients. So this one we can sincerely manage by just doing medical management. There is no edema, no swelling, hemorrhage is very small. We can always do a follow-up scan in 6 hours, 5 hours, and manage the patient at the spoke rather than bringing all the way here.
Yeah, that's a great case example, Dr. Singh, of being able to use the hyperdensity module to assess the size of that bleed and keep the patient at the spoke. Let's switch gears just a second from focusing on the impact that AI is having on patient flow and process, and let's shift to the impact that AI has on patients and clinical metrics. The promise of this technology is that it's going to aid in diagnosis and allow everyone to have access to the same information at the same time, accelerating patient management. And when we start looking at some of the data from all of your 3 facilities, you all have really similar results. This first slide shows that all 3 of you saw a significant increase in the number of ICH patients you identified after installing Rapid. Dr. Khan, why do you think that is? Why do you think that all 3 of you are finding significantly more ICH patients with Rapid than you did before?
Yeah, I think, it's probably similar to what radiologists have been saying for a long time. It's a tool that essentially adds a second set of eyes and is a nice screening tool. I mean, you're getting a lot more that maybe might be missed, and especially, in the setting where even in the last 2 weeks at my hospital, I've had 2 neuroradiology colleagues that have, left the practice and for teleradiology, and now they have body radiologists who sometimes are not reading as much. So it's just that second set of eyes that allows you to capture more folks, so that you essentially are able to get a better encatchment of folks. I don't know how it is at Dr. Singh, how it is with your institution?
So I think it will be, and that's the story of most of the radiology practices, that for us, we had one, we just hired a second person, not planning to hire a third person, neuroradiologist. But at this time, we have 2 neuroradiologists. And when they are not on call, sometimes the smaller hemorrhages or the volume or something is missed in these ICH patients. And that is not just for our patients who are just spontaneous ICH. That can happen to our post-operative, like we do a thrombectomy or aneurysm or something. In those cases also, we were missing these important bleeds. So at least the portability, the accuracy, I always go with accuracy, is so good of this particular software or AI system that it's helping our body IR. Suppose they are on call and they have not read CT scans for a few months, and they're on call in the night, or a teleradiologist who's on call at night. It gives them an ability to confidently, that confidence comes from the accuracy of the software. Now, it can, there is a lot goes into making these softwares and producing it and giving in our hands. But it has, when we deploy this in a lot of hospitals at the same time, you are kind of democratizing the care, some level of care. It's not we can't manage patient just by diagnosis, but it kind of helped us to give that quality of a neuroradiologist in some form, in small subset of patients. Dr. Nair, what do you think?
Yeah, so at the risk of upsetting you, my colleagues, we have a little bit of the opposite problem. We're lucky to have a fairly strong cadre of neuroradiologists in the private group that covers our system, and they even have a diagnostic neuroradiology fellowship. The problem is actually us. We are drowning our radiology colleagues in the tsunami of imaging volume. And it's only gotten worse as our system has grown, because it is the same group of radiology specialists who are now responsible for that growing reading volume. And so, some of this was a surprise to us, but maybe I shouldn't be surprised. Just, all of the literature tells us that as clinical shifts get prolonged, as your imaging volume gets higher, the error rate for radiologists gets higher. It's still a human endeavor. So, to Dr. Singh's point, having support tools like Rapid really, really helps you become safer as a clinician. Our biggest fear as clinicians is to miss important and clinically relevant findings. And this is a stopgap to help ensure that we don't have that problem. As a stroke neurologist, we often acknowledge that even stroke alerts, sometimes you'll get false positives there. We would much rather have false positives than false negatives. because that's much more harmful to patients. So we feel like this is the right trend that we expect to see, and we're moving in the right direction. We're capturing all of these patients most effectively, and yes, then that helps us get to most appropriate site of care. I think there's also the other side of this, which is identifying those patients that might be amenable to more effective interventions. We now live in an era where hemorrhagic stroke has at least the potential for equally good outcomes that we've had in ischemic stroke for the last couple decades. I'm lucky enough that I work in one of the sites that was part of the ENRICH trial, and we saw some just truly stellar outcomes with appropriately selected patients receiving minimally invasive hematoma evacuations. But as you can see here, the inclusion criteria were somewhat stringent and really dependent upon accurate, not only detection, but volume measurement on the imaging. And historically, we would have to do that manually. So now with an automated approach to this, you can at a glance recognize that, yes, this patient is amenable to intervention. And if they're here on site where I have my surgeons, then we're going to speed that process up to the OR. If they're at a regional spoke site, then we'll know that's a priority transfer. And so, we don't like to kind of prioritize the financial aspect of this, but I mentioned that we're a Catholic organization and we're very mission driven, but we always say in our leadership meetings, no money, no mission. And so by having a more rapid process for patient identification and triage, now we're getting those patients to the right place. We're identifying patients that are amenable to interventions. That's hitting our clinical outcomes more effectively, but is also hitting our financial outcomes more effectively. So we hope to see this trend continue. Especially we're even modifying our transfer strategy around tools like this. So I expect that this will only continue to grow.
Yeah, thanks, Dr. Nair. I love your point that this increase in ICH procedures that you're seeing is both important from a clinical perspective and providing better care for your patients, but also important from an ROI perspective that these AI modules are not, adding costs, they're actually ROI positive. And on top of seeing an increase in procedure volume, as is shown on your slide, we're also seeing an improvement in other key clinical metrics like ICH length of stay, as you can see on this slide. Dr. Singh and Dr. Khan, both of your data is on this slide, and it shows that both of your facilities were able to reduce ICH length of stay by a significant amount after installing RapidAI. Why do you think that is? Why do you think that implementing AI impacts ICH length of stay so much? Dr. Singh?
So as I think when we looked at the data in the first time when we published this, I think in our Green Journal, one of our residents kind of was interested in this. So the issue here is that I cannot attribute length of stay solely to detection or a detection module. It's more of, I would say, that when we developed our program, we used it as an educational tool. And I think we're going to discuss ICH score later on, but the issue here is not solely. It is more focused. It's like shining a light to a something, and people start paying more attention to it. So imagine my residents, my fellows, my attendings, my ICU folks, they are writing these ICH scores, they are using order sets. So that has more to do with it than just the detection itself. So it's helping. Down the line, we'll get more delineation of if we continue to, the ICH is an important stroke metric. So we're going to follow this down the line, and most likely we'll see what are the other factors associated with it. But just detection, I don't think so. LOS can be, length of stay could be impacted. But it's a very catchy, it's a very good slide to show because I think Dr. Khan and Dr. Nair also have similar experience. But let's see, what do you think, Dr. Khan?
Yeah, so I think, yeah, there's probably a part of that, but also, like we said, these are more sensitive eyes that we have. And so when you're increasing the sensitivity, you're probably capturing more smaller lesions, which probably have patients that have shorter length of stay as well on one end of the spectrum. And then also looking at the CSC data specifically, some of those large bleeds that would probably languish at our referring hospitals, they get to stay over there. If I'm the neurosurgeon, I mean, just this last week, they gave me, I got a call about 2 patients with devastating hemorrhages, which tended to languish a little bit as the family wanted to hold off on withdrawing care, wanted to give them time. And so those transfers didn't happen because we already knew that there was not going to be a neurosurgery intervention. So, length of stay, I think there's a part of it where, these are downstream effects from that more sensitive technology that we have, or more sensitive eyes from what I'm seeing.
Dr. Nair.
I think so. I agree with both of you, and I would take it a step further. I think Dr. Singh is probably correct in that you're probably not having a direct impact on individual patient length of stay, but when you step back and take a broader look at population level data, and in my quality role, that's kind of where I spend all of my days. These are huge metrics to speak to at a management and leadership level, because you're really wanting to look at this from a population health perspective. So, if you're identifying a greater subset of this population, that's how you advocate for program development, resources, and personnel, et cetera. But then also, when you look at this at a system level, right, is that length of stay being managed at the right place? Right. If you have a comprehensive, level center like all of us are functioning at, and then you're seeing a drop off of length of stay because you've now absorbed a lot of low hanging fruit, very low acuity patients or moribund patients who are going to transition towards hospice early on in their stay, that gives you some sense of how are we using our resources and our bed capacity at a system level. So I'm really excited to see this, and we unfortunately could not get access to our data in time enough, but this is one of the things that we'll be paying close attention to, because this drives our program strategy at a system level.
Yeah, I think that's a great point, that ICH length of stay is a key metric, and any improvement of it is a benefit from this technology. Our next topic is another really important set of metrics, and that's leveraging AI for stroke program compliance. And I know, Dr. Singh at CHN Nebraska, improving ICH score compliance was a critical part of your journey of achieving comprehensive stroke center status. Can you explain, why stroke program compliance is so rigorous, and tell us a little bit about your story of achieving CSC status?
So we were in our center in Omaha. We had 2 hospitals. We had one thrombectomy capable center, and we had one primary stroke center. That stroke center had a lot of specialty. It had anesthesia, neurosurgery came in, and there was all the new specialties were coming in. It was a university hospital. So when we looked at our gaps, and one of the gaps were that trauma was working in our center for the last 20, 30 years now, but they never had this concept of spontaneous ICH detection. Now, what happens is that when we don't have a lot of resources of neurologists in my center, or a lot of the brains of vascular neurology or neurosurgery is not there all the time, 24/7, then my ER doctors, my IC doctors have to write that first HMP or first consult or first exam. Now, one of the key things in both Joint Commission and DNVs, we had like more than 500 gaps. Some of the gaps were easy to do, like writing protocols, but some of the gaps, like documenting appropriately the ICH score, that is one of the few metrics in the stroke core measures, comprehensive core measures. There was no ICH volume. So we found out there is no ICH volume for these CT scans. And Rapid came in a right time, around the same time in January, February, March, and April. This was before our stroke certification. In May, we got certified. And we deployed we did education, we write some smart phrases, we educated our ICU folks, our ER folks, our NPs, fellows, residents. And within a matter of while we are getting certified, we saw the compliance has increased now. We checked it for the whole year, and we've been pretty blessed that all our doctors are able to use this. Now, before you had this very rudimentary way of checking it. We all used to calculate A, B, C by 2. For few clinicians, it's a very easy thing to do. But in our setting, it was mainly, sometimes there was a lot of discrepancy. You see just one dimension, rather than having 3 dimensions for volumes, just 1 dimension. So until unless you know how to calculate, and you are trained and you are doing it, this was becoming a big hassle for us in documentation of ICS score, which is critical part of that is a volume. Rest of it, GCS age and other things are not that difficult for a clinician to note. So this tool has, as in any program, this tool has become a teaching tool or education tool for our residents, our fellows, our clinicians. And the accuracy is pretty great. And I was mentioning initially also, the accuracy of this particular, not all AI are same. You can have AI from Google, you can have AI from OpenAI, but they're not gonna be the same. Same way for imaging-based detection, the accuracy of Rapid is far greater than whatever is available to us. And it is so good. I was looking at some FDA data and algorithms, and the kind of patent or the work Rapid has done, it is very, very accurate. And that's why there was some question also, that's why if you use a more accurate tool like that, it helps us to future advance the research in this field. And as Dr. Nair was mentioning, to do this, that's why Rapid was chosen for Enrich, that it is a very, very accurate measurement. So it took a lot of burden off during that during that tough time for a few months, because as you know, like you have hundreds of physicians, how everybody will give you 100% compliance all the time. So it was a very great experience for us.
That's a great story of you and your team. All the kudos to you and your team about setting a goal and using every technology in your toolkit to be able to achieve that goal. Well, the last topic we have this evening is reimbursement. And we just talked about how, clinically, operationally, and from a compliance perspective, there's a real need for AI in hemorrhagic stroke. But, the reality of the American healthcare system is that reimbursement is also something that we need to be mindful of. And luckily, rapid hyperdensity has a T-code associated with its use. And Dr. Khan and Dr. Singh, you've both been using these modules for a very long time now. And your facilities have extensive experience using this code for rapid hyperdensity. Can you tell me a little bit about your facility's view on the reimbursement situation for rapid hyperdensity?
Now, if you look at the amount of CAT scans and we do in our own hospital, the times on the same patient number of CAT scan we do, it's a lot of money and a lot of CAT scans system-wide. So the issue here was to sometimes this whole module of ICH, and correct me if I'm wrong, that if you do more than, we do close to like 20,000 to 25,000 scans per year as a part of stroke evaluation. Not everybody has ICH, but if they put the radiologist put just one line saying that in their report that they have used this technology to, for their report of volume and detection, that is like 580. And if you multiply with number of scans we do, that becomes a great for institution and for recovering the cost of the whole modules, and for me, for everything. So it was an appropriate payment for appropriate care, I would say. And this dollar sign, I don't think so any of our administrator will dislike. And this became a very good tool for us to get some approvals for different kind of modules. What do you think, Dr. Khan?
Yeah, I mean, I've been in a few meetings. You know, my current position, before, right around the time I started, we didn't have a AI technology for detection, and then it came about. The hospital had been experimenting with it in the last year or so, and it's very easy for me to advocate for it because these modules have an appropriate payment and a rate that justify its use. And so, from me as a clinician, I don't look as much. I'm not the one looking at the dollars and the cents, but it's very easy for me to push for something that makes my life easier as the clinician when it's able to essentially cover its own costs, and I'm able to then make the argument for expanding AI use system-wide.
Yeah, I think the only thing I would add to this is, we have some internal data that we've been reviewing, looking at that same number of patients that would be receiving these T payments, right? And we're probably underselling this. One of the things that we picked up on is when the ICH module and the hyperdensity module was released, was that we had a clinical standard across our entire system that automated the ordering of CT angiograms for all of our presenting stroke patients, including our hemorrhages. And so what that meant was we were absorbing a lot of additional cost for imaging that was in taking out of the DRG reimbursements, even when they were clearly deep hypertensive hemorrhages without any concern for a primary vascular anatomical cause. But even then, at a system level, I think we had something like 8,000 patients who received a plain CT without going on to have CTA afterwards. And so here you're talking about if that's the patient population presenting for a suspected stroke with a rapid tool now implemented, I'll let you do the math. 8,000 times this average payment range, you're looking at a pretty substantial reimbursement that is reflective of the work that's being done for these patients, right? Because it's not just that you're applying the tool, it's guiding your clinical management, and now you're being more discerning about what it is that we're doing for patients, especially if you're able to minimize the use of additional contrast exposure, additional radiation exposure. These are all things that we're mindful of now in clinical medicine. So it's a both and. So what we're hoping to see is that this will actually drive us to be a bit more individualized in our patient care.
Yeah, thanks everyone. Those are super valuable insights, especially when you consider that those patients are going to, save on not getting those CTAs, those potentially unneeded CTAs, and also benefit from the reimbursement situation. If anyone in the audience has any questions about this topic, you can always reach out to us at RapidAI via the email address on your screen, reimbursement@rapidai.com. And that just about does it for the content of today's discussion. But before we jump to some Q&A, I just wanted to summarize some of the key points that we covered here today. First, we discussed how AI in hemorrhagic stroke helps to optimize patient flow and both transfer and treatment decision-making. Secondly, we discussed how AI acts as a second set of eyes and has shown to find more ICH patients and supports appropriate intervention. And lastly, that AI for hemorrhage comes with not only operational, but compliance and financial benefits as well. And now we'd like to open it up for some Q&A. And if you have any questions that you would like to ask our panel today, please use the chat box on your screen. And I'm going to pull that up. Here's one question. Could the length of stay reduction demonstrated be associated with more patients receiving minimally invasive procedures, which have shown significant hospital length of stay reductions? Enrich showed a 3-day reduction in the intervention arm versus medical arm.
So for this particular question, I think Dr. Khan also has some data, but the way when we don't do those intervention, we were not part of the Enrich trial. So I can definitely say that a minimal invasive surgery, we don't have that. There is a specialized module is needed in your neuro navigator for our neurosurgeon to do these tests. And we are still in process of getting that in our healthcare system. So we don't do those procedures, but still you can see that there's a drastic decline. So I can definitely, from my end, N is equal to 1 at my center, I can say that intervention, and you can, not just surgical intervention. For me, it's more of that recognition that there is an ICH, spontaneous ICH is important diagnosis. You're putting that in your notes, and the medical interventions are more, in my mind, I don't have data for it, but we're gonna look into it. But medical intervention, like blood pressure reduction or reversal or rechecking the CAT scan, right? Starting antihypertensive IV, placing the patient appropriately in ICU. Those things have far more value. And meeting all the metrics for ICH has far more value than pure neurosurgical intervention, because we don't do that. What do you think, Dr. Khan?
Yeah, I would say that, I also was not part of the Enrich trial, or at least our site was. A few of our neurosurgeons, just within the last couple of months, especially after, the data came out, have been more open to doing some minimally invasive procedures, but they come far and few in between. And, those minimally invasive, I myself, I still actually advocate for a larger, I sometimes advocate for a craniectomy, a large one, to relieve the pressure, as opposed to trying to use some of the new technologies. That's a topic for a different webinar, a different discussion. But in my personal view, I haven't seen those procedures be the cause necessarily for why that length of stay has necessarily decreased.
Yeah, having been a participating site, I can tell you that certainly there were many patients where we saw pretty immediate and dramatic improvements. One case in particular stands to bear. Picture perfect hemorrhage, just lateral to the thalamus, compressing the internal capsule, and the patient was completely hemiplegic on arrival. And so, under historical conditions, that patient would have had a multi-day stay in the hospital, initially ICU, then followed by step down to the stroke unit, and eventually probably to inpatient rehab or to a skilled nursing facility. Post minimally invasive evacuation, that patient was up on his feet and playing basketball in our rehab gym on day 2. So yeah, there's definitely some patients that will have these dramatic improvements. I would say that, if you have tools that can more rapidly identify these patients, the key, in my opinion, is rapid intervention. When we have looked at some of the time-bound data on hematoma evacuation, I think there is something to be said for earlier intervention. I think we know less about what those time boundaries are, and it's probably very individualized to each patient brain. But I think in general, there's probably a trend that earlier evacuation is better. And so you need that early detection, you need that early identification. And at some point, that's going to have some impact on length of stay, but it will depend on your surgical volume. And so we'll see as there's some additional trials that are either underway or about to be. So I'm hopeful for the future.
Yeah, there is a follow-up question and Rich, about the REACH trial. Dr. Nair, do you anticipate utilization of RAPID for REACH as well?
It wasn't part of the study design, and we're in talks to be one of the participating sites. But I would guess that if you have access to it, absolutely, that should be a factor in your decision making. Partly because you'll get immediate measurement of the volumes, but also it'll give you a better sense really of what is the localization. And so, REACH is going to be the deeper hemorrhage corollary to the enriched trial. And that's a little harder, right? You're traversing more territory surgically, and I defer to my surgical colleague on this call, but that already is going to make it more challenging. And in our early data sets, and going back all the way to the MySpace days, those were the challenging cases. But remember, back in those days, we didn't have a triage tool, right? These were eyeballed patients, and then you would have to go through a lot of manual image post-processing to even get to the point of enrollment. And so, I can see tools like rapid hyperdensity being a game changer even for study enrollment. That will be much more efficient now.
Yeah, I'd probably agree with the aspect in terms of standardizing, because, like Dr. Singh was talking about, I mean, you can use different sorts of calculations. If you have something that's able to standardize and, have one surgeon speak the same language as another in terms of volume, in terms of location, in terms of, exact measurements, it helps to be able to then characterize and compare apples to apples, essentially.
That's great. Let's see here. There's a couple of questions about implementation. What were the biggest challenges in implementing AI or rapid AI for hemorrhagic stroke?
So for us, it was like, I would not say a challenge. We had so many scans that we realized that we don't have, and for some reason, our system over the weekend used to store all that in somewhere. And we were seeing some crashes, like users were saying that they were mobile applications crashing. So it happened once, maybe once. And the Rapid team, the customer service, we kind of did a deep down how these things are stored and why it's crashing. And it took us like 34 hours to fix it. We found that based on some of our requests, we wanted to store all that 48 hours images somewhere. and with the number of users and scans increasing, that was crashing the system. But other than that, I think initially, since it's been there for a very, very long time, people have either heard of it, or this is one of the first AI tool ever formalized in one of the first image tool in AI for medicine. So we are talking about 2010, 2011. So at that time, OpenAI was not in existence the way it is. So it was a great. So people are very happy with how it's implemented. There are always going to be technology, but as we are getting better at it, with newer cloud platforms, more nimble algorithms or UI interfaces, better user-friendly, I would say. So those things are very helpful.
I think the challenging side is not even on the implementation of the tool, and I think all my colleagues are talking about this. It's really how do we incorporate that in our clinical decision making, in our workflows. So there has to be some flexibility and adaptability. We shouldn't be doing things the way we were doing them manually, right? We should also be we should accept the value of the tools that we're implementing and allow that to change our workflow. I don't have to work as hard today, and I'd rather not. So, I think that that's probably been the biggest change and biggest challenge internally, is sort of just the culture shift of, hey, you don't have to do that manually anymore. Let us, change the workflow around. We can be much more efficient and more productive as a result.
Yeah, I think, the folks on this webinar obviously are advocates, and we found the benefit of it. I have colleagues right now who work in my same office space or work down the hall who don't want to be notified. They like having the workflow where the emergency department gets the call, the mid-level then gives them a call. They then can kind of plan things out. They don't want the extra thing. So, I mean, there is some pushback, obviously, whenever there's new technology. Old workflows are disrupted, and so it sometimes comes down to that, personality thing, which in the surgical field, you'll have folks that sometimes like to do things a certain way. And that's always going to be there. But as more people see that benefit, once it comes to the point where, someone's night, you are able to you're able to plan your night, maybe sometimes a little better, or plan your day so that you can think ahead of time about whether you have to come into the operating room, make dinner a little bit earlier or something like that. That's when I think folks will, even the ones that are a little bit steadfast in their ways, may come around a little bit.
Yeah, and it's funny, Dr. Khan, you say making dinner. That is one of the examples that we use, sitting around the dinner table, and you get your push notification from the RapidAI app and dialing in and assessing a patient right at the dinner table. Great. So I think the last question that we have today is at the beginning of the presentation. It was mentioned that Rapid has a module for subdural hematoma that can differentiate between acute and chronic clot. Why would that be important? SDH is considerably less urgent than acute ICH.
So I think from endovascular point of view, we are seeing that is a very timely publication by RapidAI in their modules. I have not used it yet. Maybe I will. But the way we were seeing that in ICH modules, we are detecting these subdural hematomas, some of the ICHs, acute and chronic subdural hematomas. Now, the old blood is a difficult ball game. That old blood in subdural hematoma, both in terms of I just remembered that there was a chronic hematoma, which was subdural hematoma, which was called as language was changed in the report. And this is a very remote place where they reported it as hygroma. So for an ER doctor, that hygroma is he can give that patient TPA. But if you're calling it as a hematoma, then you cannot. I just remembered that particular case. And the second thing is that we are having very good trial result for embolization and preventing the recurrence of subdural hematoma. And this will have a bigger impact down the line in adding a new procedure to our list that will become standard of care in 2-3 years of time. So we are in last year International Stroke Conference, this year International Stroke Conference, many presentations were made, and we are solidifying the indication and how to use it, how to use MMA EMBO, both pre-procedure, para-procedure, or as a standalone isolated procedure in an outpatient setting. So it's very helpful. These patients they have a diagnosis of dementia actually, and they're very difficult to diagnose, and with a lot of variability about reporting system. It's a very, very good tool and very rightly timed tool for us to use in next many years.
I would also add the simple neurological aspect of this. Subdural hematoma is one of the largest growing populations in our field. The VA did this great study about 10 years ago showing that's soon to overtake all other neurosurgical diagnoses combined. And a part of that is aging population. But one of the things that we on the neurology side see frequently are patients who present with new onset seizures or even transient neurological episodes. And it's not uncommon for, as you pointed out, Dr. Singh, smaller chronic subdurals to get missed or miscategorized as characterized as hygroma. And there are these interesting clinical phenomena. So seizure in the setting of chronic subdural is one, but also nesis, which is essentially just transient neurological symptoms being triggered by presumably the altered electrolyte and metabolic environment of the cortex, but without EEG correlates and without active ischemia. So those patients can be managed very conservatively, right? Mm-hmm. So I think having early detection and having accurate characterization is really vital to managing these patients in the most safe and effective way.
Yeah, that's great. I think that just about does it for questions. So I'm going to close it right now. Thank you, everyone, for joining us today as we explored how AI is transforming hemorrhagic care. We appreciate your time and your engagement, and we look forward to continuing this conversation together. If you're interested in learning more about our hemorrhagic solution, please reach out to your local rep or simply fill out the Contact Us page on our website. Thanks, everyone.
Thank you.